We are very happy to have you here and our professionals who have just arrived. Privileged to have the first keynote. Before that, I would want to say that when you see the GND origin, just one statement. From a university background, one thing I asked Professor in 2014 is that if you're pushing me to go and become the first CEO of nutritionists and dietitians, and with an act where there are no structures, am I not going to lose my mind with the research? So what am I going to do when it comes to the passion of research? And he told me, you just go. And we can even initiate a journal. And you remember the first time in 2016, it was resisted that a regulator cannot have a journal of nutrition and dietetics peer reviewed. And we pushed it to 2017, and 2018 we launched the first journal. In 2018 we had GND, no indexing, but then after that we started the indexing process, and we came up with the editorial board. So Professor and I are in the board. We have other 4 members of GND. And the journal has run a series of conferences. This is the 5th in the series. So we have indexed now with the AJO, that is African Journals Online, and we are also cross-reft. We are both print and online, electronic. And very soon we are completing the process for Scopus. So then the journal becomes a platform for African nutrition science. We also allow for international publications. So feel welcome, and I will give the first keynote. I know that there are members of the 4th estate in the house. Very interesting. Edgar, you said we need to have media on board. This is a place of media. And Kenya cannot run without media. So the members of the 4th estate in the house, I think is KBC, correct? Is Cheriot there? Oh, Cheriot. So Edgar, sorry, this man, Cheriot, has lived with KNDI from 2009 to date, and is a media mobilizer. Sometimes I'm asked, where do you get the money to be on media all the times? Don't worry. So we shall be there together for both county. Good. So I want to believe that I'm between you and your team. And so I will not spend more than 1 hour out of this. But I have a keynote that is a bit different. It's not the academic research, but it is focusing more on professionalism. And when we talk of professionalism, we are talking about the person in charge of nutrition service delivery. And so on the slide, I think we can share that. It's already up. You can put up the slide so that we can follow. Good, thank you. The title of that keynote is Strengthening Health Systems through Supervised Pre-Service, Industrial Attachments, and Internship of Health Professionals. Why am I talking about health professionals? I don't want to talk about nutrition professionals for now, but I'll use a case of nutrition professionals to also enhance the component of other health professionals, also working in the sensitive areas of nutrition. And we know that we cannot lie. Other professionals also touch matters of nutrition, either indirectly by allowing nutritionists to be in the space of operation, or by doing it when the nutritionist is not there. And it is something that we cannot say does not exist. So just by way of introduction, and I want to be very specific on what I communicate, because a lot has to do with the policy. I would want to say that when you talk of industrial attachment and internship, that is something we thought about in 2015, and it somehow stopped in 2021. And the reason was that you cannot put professionals on internship when they're not paid. But of course, it is still continuing at the pre-service as a concentrated component together with industrial attachment. So why strengthening health systems? And you know the language in Kenya, UHC is our big brother in the house. And many times you've heard that professionals of nutrition are complaining that they are not included in the UHC program. And if they are included, they are not given priority when it comes to decision making. And this is something that we have noted even with the unions. And we wanted to come as a strong team, and now that San is here, so that nutritionists can get their rightful position, even as they work with other cadres. Now, universal health coverage within the WHO definition framework implies access to key promotive, preventive, and curative, as well as rehabilitative interventions for all at an affordable cost. We all know this definition from WHO. I always tell people, WHO defines, but we adopt. So we adopt according to what we have as our capacity. It is not a rule. It is not a law. But it is a guideline that we can borrow from. So we say this definition does not clearly identify key areas of focus and may overlook quality aspects. And there are proxy determinants. I was saying that because when you're given a definition, there are certain components that are left out. And I was just remembering when Prof said that where is the community capacity? And it came to my mind that we instructed him sometimes back to do the capacity development framework for Kenya. He spearheaded that process, and I think he picked it from there. Now, we cannot overemphasize the importance of UHC in Kenya, and of course, beyond Kenya, as a priority for WHO and other member states. And of course, given the current implementation focus, the emphasis is more on pooled prepaid healthcare financing system than on promotive quality healthcare. And you see the shift is more of who can pay and who is to pay for that person. But we're not looking at what to be paid from a broad perspective, because a lot of budget goes to the curative component. And because of that, we also know that it will be of significant policy focus to explore key components of universal health coverage in the contextual technologies such as universal healthcare and universal health coverage. That was something that was thought about even before we had the SHA that is there. And so some scientists have argued that universal health coverage is linked to health systems reforms. And so if we want to reform the entire system of health, then we must bring in UHC as a component. I'm saying that because of the sector under which we are. However, it is essential now to note that UHC focuses on the provision of a range of healthcare services, now whose delivery would require adequate and competent healthcare worker. So my focus is on adequate and competent healthcare worker, both at the facility level and also at community level. And apparently, healthcare workers are drivers of health reforms and health systems. And they do this without a sound and competent driver. Even a powerful vehicle would not deliver maximum results. So if we are talking about healthcare delivery of service and we lack competent personnel, then we cannot be assured of access and adequacy of the service. And so repositioning current health care worker, particularly medical personnel, would meet the demand for UHC. And when you talk of medical personnel, we are not talking about a medical physician. We are talking about a nutritionist, a physician, a nurse. All the frontline team members are medical personnel. And these people must speak the same language. Now, from the nutrition lens, they must speak nutrition as a multidisciplinary team because each one of them touches on nutrition, but being led by the professionals. So proper skills for such healthcare workers are likely significant gap across many cadres at pre-service training. And so it is understood that the pre-service training encompasses formal, theoretical, and of course basic training and practicum. And practicum is often implemented in two forms, that is industrial attachment and internship level. And in our caucus for CEOs of regulatory authorities, we have always talked about a supervised internship program and supervised industrial attachment programs. And we know that many health cadres in Kenya have internship programs, and this is determined from time to time. Now, the dilemma is whether such programs are adequately supervised the way we do. And if you are a medical professional in the house, don't be intimidated by the nutritionist, because we want to give you a case that you can follow from the KNDI's perspective. We can move to we are on the next slide. KNDI internship and legal framework. And I want to be very keen so that all our professionals can understand this very well. It doesn't become a point of argument. Now, the internship and industrial attachment framework is guided by the provisions of CAP 253B. That is the Nutritionist Act number 18 of 2007. We have asked nutritionists many times if they know the name or citation of the act, and 90% have failed. Today we are saying the act is cited as Nutritionist and Dietitians Act number 18 of 2007, which commenced to work in 2009 after the first gazettement of the council. Now, under section 6 D and G and section 13 BD, if you look at the table, there are operationalized sections of that act that deals with purely training of professionals. And so you will notice that, first of all, KNDI has been given the mandate to approve training institutions for purposes of training competent professionals. And in section 13 of the Act, it provides for training of persons. And in this case, there is also preparation of syllabus or the core curricular guideline that needs to be used, and then developing regulations. So, Edna, if we were to get into the strengthening of nutrition service delivery, then having a policeman by your side alongside service would also be very important in advocacy and lobbying when it comes to county government. So the KNDI's industrial attachment and internship models are implemented in two phases, which I want you to take note of. The first phase, which is industrial attachment, is looking at the trainee at certificate, diploma, and degree level. And these two domains we have, in these two areas, we have two domains. We have the community level attachment, where students are placed in AGOs and EDNA and community programs. So we insist that all universities and colleges, they have to place them for 3 months in such community systems. And you see, nurturing them at that level would be very important. And then also we have those that go for clinical rotations, again for another three months, where they engage with health facilities. And during the standard term of the semester sessions and facility clinical attachment, we have what we call a concentrated practicum, which also run. And we expect that all these can give us up to equivalent of 960 hours. Now, we have the degree level also, where we also engage in post-graduation internship. That is the one I've said we stopped in 2022. And the reason for stopping it was because of non-payment of interns, though it is still running as a concentrated program. Next slide. Can we move to the next slide? Yes. So if we are looking at the industrial attachment and internship model, this is what we have. For purposes of understanding, on the industrial attachment arm, we have the community level attachment and we have health facility level attachment, which both takes 3 months. Now, in terms of semester and term level for training, we have weekly concentrated practicum at level equivalents of 4 to 7. What this means is that every institution must have 7 hours a week at health facility, level notwithstanding. So if they're diploma, they have to be in the clinics 7 hours every week from day one of their admission. And also if they're degree, the same. Now, when they have graduated, then we have a 12-month post-graduation internship purely for the degree. And that will go to different areas, community, we have the county, we have health facility and the food industry. And then they undertake professional examination. So the professionals that are accredited are those that have gone through our system. Next slide. So KNDI developed a training guideline, standard guideline for the universities and colleges in 2012. And this was to guide the training process. These standards are verifiable through checklists, which we have, that specifies all training requirements at all levels. And within the standard checklist, indicators related to students have been prescribed at the pre-service industrial attachment model, which is categorized into two. We had said the initial attachment places students within clinical health facilities accredited for that purpose. So we don't just send them, we send them to the accredited centers. And then the second attachment places students in community settings, which of course are NGOs, and these are those touching on matters of nutrition. In both cases, training institutions assume full responsibility for assessment. And that means we have signed MOUs again with all the centers and counties. This component will give us, as I said, 960 hours of practicum equivalent hands-on experience. And so when we combine that with the post-graduation for degree, students who graduated already had 2 years work experience, and we needed not to subject them to other experiences before they are employed. That was then. And I've also talked about the concentration. So I will skip the next slide and go to the industrial attachment implementation plan. Now, if you look at that table, which I call table 2, you will notice that at the certificate level, the total number of hours for hands-on practicum is 1,128. At diploma, we have 1,212. And then at degree level, we have 1,296. This is the minimum we expect from the professionals when they are accredited or licensed to practice. on the basis of hands-on experience. We move to the next slide. Now, KNDI's model, and I call it KNDI's model because it is our own innovation, is guided by CAP 253B, internship guideline also developed by the council, which we initiated in 2015. The internship is a 1-year program. And 1 year means from January to December for a calendar year. And the model for the degree program is the one on focus because diploma, they only do professional exams. So we want to present for you the professionals we have in the country, which has not been adopted by any policy in the public service. And it is at the moment that now we are working towards that. So we have 6 areas of competency building for a degree holder professional. Next slide. If you look at that diagram, we thought as council, number 1, when this act was created, and it's the only one in the world, I want to say that with confidence, there's no any other act of parliament for any country. It's only Kenya. Even if you go to America, we only have American Dietetics Association, but we don't have a regulator unless news come. Now we asked ourselves, who is this creature called a nutritionist or a dietitian? And what we said is that if you were to do a BSc program in nutrition and dietetics, we would have 2 creatures at the end. One would be a nutritionist and another one would be a dietitian. We asked professionals to define who a nutritionist is. And people gave us different definitions. But we finally came to a conclusion that we have 2 creatures. One could be a nutritionist. The focus is on science. And another one could be a dietitian. The focus is on diet management. And so out of the nutritionist, we categorized 4. We had clinical nutritionist, basically working in the hospital facilities and clinical settings at community. The focus is on trials and also service delivery on matters of diagnosis and assessment. And then we had public health nutritionist. I had Edgar defining himself as a public health nutritionist by virtue of his practice, not by training. And we look at this at macro level. When I talk of macro, we want to see these people dissecting policies and analyzing them at national level and at county level. So their focus is on orientation of policies, which determine nutrition space in the country. And then we have the community nutritionist. These ones, they are at micro level. These are house to house. And the question I've always asked, when the Kenyan government was instituting the act that introduced community health promoters and gave them the responsibility to take charge of nutrition advice in the country, the question was, where did they train? And so our approach was to emphasize on the fact that government, both national and county, must, and I'm saying this from now the regulator's perspective, must have a mechanism of capacity building the community health promoters through community nutritionists. And so the counties must engage this creature at that level. So they are house-to-house creatures, and they can advise at that level of community. Then we had the food science nutrition, the nutritionist. The food industry has quite a lot for us. When you go to the supermarket, you see a lot of claims. Some of them are valid, some are not valid. Now, who checks the claims? We created food science nutritionist. And we said they don't just work in the food industry. They can also work in the hospital facilities. And the question was, who procures parenteral feeds, for example? And who scrutinizes that they are valid and have health integrity? If you go to a health facility now, this is a service that is offered by the nurse. unit, the head nurse, and the pharmacists take charge because they think it is medicine when you are procuring parenteral feeds. But this is food. So who takes charge? It is the food scientist that can take control of that. Such creature is not in the health facility, but we are creating them. When you go to the value addition at community level, a product has been produced, or you want to translate a real food in the system to products that can be sustainable. We need value addition techniques at the community. These are food scientists. This creature is there, but it's still not doing the work. Now, on the dietetic side, we introduced two types of dietitians that is not there currently. One was a clinical dietitian. The focus here is on interpretation and formulation of diagnosis. And so these are the people who tell us how much somebody would require in a health facility. They have not touched the food, but they tell us we need this amount for this patient with this condition. After that, then they have to pass this to a food service diet therapist, who then manages the kitchen aspect. And this is where we went wrong with nutrition, because many hospitals thought that nutritionists are cooks, and so they have to be found in the kitchen. Now, we have a food service diet therapy whose work is to guide the menu process for the catharesis. And so when we were coming up with Regulation 48, we insisted that the nutritionist must be part of advisory for the kitchen in a health facility. And we also insisted that kitchen must be moved away from the mortuary, so that we can enjoy the food in hospital setting, which will meet our requirements. So we have produced these creatures with our target that we make nutrition service better, all the way from the field to the health facility. Next slide. Now, during the period between 2015 and 2021, the program was implemented with the help of internship unit here and faculty members and preceptors. And I want to talk about the three. At this unit of internship, this is purely administrative at KNDI. But when it comes to preceptors, we have those nutritionists that are already working in the health facilities that we have accredited and qualified as super trainers in the health facility. I'm saying so because not all of them can train. And we also have faculty members, those who are teaching our professionals at the universities. And these three come together to run this program so that they can train the professionals during the internship program. And they do comprehensive assessment. We did this by placing interns in 47 health facilities in the country. And every year we placed 500 nutrition graduates in health facility, which, if it was to be implemented well, we would expect impact in our health facilities when it comes to matters of food and nutrition. And the assessment program is rigorous. Unlike the medical professionals who are placed as interns and they are left to operate as service providers, these ones were intensively supervised so that we have hands-on supervision on site with the preceptors there. And how were they supervised? We had faculty members' assessment score, where they go from time to time to check the progress of the students. And some of you, I know, participated in that. And we also had a weekly journal. Now, we expected them to keep all daily activities in a format that we prescribed per week, so that at the end of it all, they can give us an analysis of the key cases and episodes. And why cases? So that we would learn from the existing cases and come up with better areas to focus on in research and also in service delivery. And they were doing this for a period of at least 9 months. Now, in the next slide, we have talking about subspecialties of clinical nutrition and clinical dietetics, which were purely on level 4, implemented at level 4 and level 6 to level 6. So we insisted that clinical nutritionists and clinical dietitians are higher level competencies that would require inpatient service delivery. So we placed them there. And then for each, we had a supervising preceptor where we agreed on MOU. And these interns were supposed to keep logbooks, which we would remotely assess at the institute with the help of the faculty members. And there would also be a very clear and detailed master rotation plan for this nature of cadre. And so when they end their session, we would then give them professional exams to now qualify them. I think that was a very good idea up to that point, until where it stopped. Now, I want us to go to the next slide so that I can talk more there. The table where we have the so far trained professionals. You can move. Move again. We'll go back to the other slide there. Now, if you look at this table, it tells you clearly from 2015 or so, 2016 to 2021, we had placed it up to a total of about 8,000 professionals. And Edgar, these are professionals who are existing in the nation. Adding to the previous ones, making a total of 14,500. Now, out of these 14,500, in our records, only 20% are either working in the private sector or public sector, which means that we still have most of them hanging outside. And the reason why they're hanging is because the shift of health system is focusing on nutrition service without nutritionists. So there's a tendency of bringing in the nurses and other cadres to undertake nutrition service delivery. Now we are looking at, is it a good idea? That is a question that I would want this meeting to address. Is it a good idea? Now, we have put on board those that we need and we trust that would offer services to strengthen the nutrition service delivery. But they are still out of place. So the next thing is, how do you bring this group on board? Now, go back to the food science wheel in the slide that you passed. Now, leave it there. Now, you've been seeing that KNDI, go back to the wheel. Stay on the wheel. We developed this wheel with a focus on food, science, nutrition, and that was to enhance the service delivery at food industry level. And we believed that every food company that is claiming nutrition in the context of public health must have a nutritionist. And that nutritionist is a food scientist. And so we came up with that model to strengthen the food industry. Now, if you go through the records, we have done up to 490 food companies on matters of nutrition. That was a market survey we did as per the audit. And they have 4,970 food products with the nutrition claim. And we only have the number that you have seen. We have not trained up to 40. Now, in as much as you are talking about malnutrition being eradicated in 5 years, that is a dream. That is a dream for me. Because we must therefore strengthen the human resource. And I was going to ask Professor and yourself, Edgar, the focus is more on budget allocation. Where is the focus on human resource? I heard from a sector where we were discussing about HRH, and we were told that nutrition work can be done by anybody. And most of those who are spearheading this process are actually the CSOs, Edgar. Because we battled with those who say we want an expert called nutrition nurse. So it has to be a very stern warning until they are to recognize that a nutritionist exists. But we also must recognize that nutritionists cannot have all managerial skills. But then we must absorb all these nutritionists. And the only route is through our collaboration. Can we also say that all the 400 dealing with nutrition and dietetics, can they absorb our professionals in the mix of other health cadres to strengthen nutrition? Your work would be easy at the community level and also at national level. Why am I saying this? If also the 5,000 plus health facilities in the country that are listed, each can have one nutritionist, they would have all these nutritionists absorbed. The problem is the health systems don't accept nutritionists. They don't acknowledge them from the DG going through to the top. And they would say, we don't really understand what nutritionists are supposed to do. That is not the case. They don't understand the framework of nutrition. And that is why from the word go, we are saying we have to now change the recognition pattern of nutritionists and dietitians to accept the current expertise that we have trained. And that starts with the public service. So my keynote was not an academic keynote, but to start the process and indicate why we are here. Other than the academics, we must also strengthen systems from the perspective of human resource for health. And we must give position for nutritionists to be heard. I remember when we were doing the pre-conference workshop, we were talking about a nutritionist being accepted to take a frontline lead on matters of nutrition where we have a consultant physician. And it was very clear that we have 1 unit weight. A nutritionist has equal weight as a consultant when it comes to frontline service delivery. If we have all these nutritionists properly trained and released, then we can start talking about reducing malnutrition. Hallelujah. I would want to stop there and open it up now for serious discussion. Thank you very much, Prof.
Let's clap for Dr. Okeyo. I know he has left it.